All right, you're recording, so whenever you want to get started, you should be good.
Turn on the mics.
Yeah, go ahead.
So everybody can hear me.
Yeah, go ahead.
All right. Hi, everybody. My name is Charlie Gatt. I'm the chairman and program director of Orthopaedic Surgery here at Dr. Johnson. This guy's asked me to come and talk to you today about getting into orthopedic surgery. So I think, other than this first row here, everyone else is at M1. Is that right? So some of you may be committed to orthopedic surgery and already know that that's what you want to do. And some of you may be just thinking that it may be what you want to do. So I think it's important, if you are even semi-interested in orthopedic surgery, to realize that it is one of the more competitive subspecialties of medicine in action. And fortunately, every year, a good number of people come to national orthopedic surgery. So there are more applicants than there are residency spots in the United States, and you have to take that into account. So what I try to do on this talk is kind of talk you through medical school and all the different stages of medical school where, you know, your performance is going to affect your ability to get into orthopedic surgery. I'm not here to talk about orthopedic surgery. You know, we have other talks to the Orthopaedic Interest Group where we address the different subspecialties of orthopedic surgery. But needless to say, it's a great field to go into. I'm glad I'm orthopedic surgeon and I wouldn't do anything else. But in national orthopedics, I probably don't think that's not yet. There's nothing else to do. Since it's a competitive subspecialty, I can tell you, like, for our residency program, we have 3 spots per year. For those 3 spots, when we download applications, which we will be doing in the early part of October, we have the option of downloading probably up to over 500 applications or more of people that are applying. And so for our 3 spots, we don't really want to review 500 applications. That's 200 too many. It's probably 300 too many, but we've chosen to pick a number of about 300. So the question is, how do we choose which applications to download? After we choose 300, because we, as a general rule, we will review about 300 applications. We invite a little less than 50 people for interviews. And of those 50 interviews, we probably rank about 47 to 48 people. We tend to find 2 people that, based on the interviews, we don't think that they're a great match for our program. Personality-wise, whatever the case may be, we prefer to not have them here at Rutgers. Doesn't mean they're not good candidates. They're just not great candidates for us. So you see this kind of tight funnel process that ultimately, of all these applications that are out there, we're going to get 3 residents. And truthfully, we get 3 good residents every year because the students that apply for orthopedic surgery tend to be near the top of the class. They're bright and they're go-getters and they have to do all this stuff to get to orthopedic. So, you know, it tends to work out pretty well for us. The stress is more on your side as medical students, because everyone who applies for orthopedics, almost regardless of how good of a candidate they are, there's an outside chance that you might not match. And, you know, I've seen some really highly qualified candidates not match orthopedic surgery. It's very disheartening for them and for us as advisors for medical students. So, that said, you know, the first 2 years of medical school primarily are sitting in classrooms like this and listening to lectures, and really don't get much exposure to musculoskeletal medicine. Do anatomy, and, you know, now there's a lot of the lectures are systems-based, but suffice it to say that one of the most poorly educated sections of medicine is musculoskeletal medicine, which is somewhat ironic because the second most common reason that patients present to a primary care office is a musculoskeletal complaint. So even family medicine physicians and general internists see musculoskeletal complaints all the time, and they feel poorly educated about that. So your medical school happens to be pass fail for the first 2 years, right? It's not honors pass fail, it's just pass fail. So once again, you're trying to get into a specialty where, it's competitive. So all of you are trying to figure out, well, how am I gonna separate myself out from the crowd? And it's not gonna be based on your grades in your first 2 years, because hopefully you pass everything. If you're failing, you're in big trouble. So your grades are not gonna be that critical. But it is important that you pay attention, because the next step tends to be part one of the boards. Now, up until this coming year, the part one of the board scores was a big part of your application for orthopedic surgery, because you got a board score, and the score was our way of screening out our applicants. So, for instance, we said, we looked at a minimum board score, and if your scores were less than, I'm going to just throw out a number because it tends to float around 235 or 240, you wouldn't even download the application. And by setting a minimum on the boards, we got to get rid of 200 applications or more that we didn't even have to read, which was easy for us, but not great for the students that did well on the boards. Now, you take part one of the boards after your second year, and then you take part two of the boards after your third year. And so now that they've decided to make part one of the boards pass fail, what did that do? It just pushed the problem down the road. So now your part one scores are meaningless because you're going to get a pass. And you're now going to have all this pressure on you to do well on part two of the boards. And once again, we don't have a better way to screen applications if you want to know the truth. I mean, I've talked to other residency directors. I'm part of the council of orthopedic residency directors. So as this has been thrust upon us, not that we had much input into the decision, we are now faced with the upcoming years knowing that our applicants, our first screen is probably going to be based on part two of the boards. And you're going to have to take it early in your third year. That doesn't mean at the very end of your third year, early in your fourth year, so that the scores come out in a reasonable time. Everyone's going to be taking them in either early, I assume the earliest date possible, which I think is going to be early July, so that hopefully your scores come back in mid-August. Because the application cycle, your applications start, and you start submitting your applications in September. So if you happen to get a under 235, which is a middle of the road score for orthopedic surgery, again, the chances of having your application downloaded are relatively low. If you get a really low board score, your chances of getting your application downloaded are close to zero. So if you get 200, for instance, you probably have almost no chance of getting an application other than maybe some institutions where you rotate through. So we'll talk about that a little bit. So, this is the world you are now living in, and the world you're going to deal with. There's nothing you can do about it, and there's nothing I can do about it. You just have to realize that that's what it is. So you're obviously going to pass part one. If you don't pass part one, you have to move on to medical school, I presume. So everything's going to land in part two. Now, the medical school does have the AOA, the Medical Honor Society, and theoretically that's the top X% of the class. So, even though you get pass fails on your grades, there's some behind the scenes monitoring of your grades, and people do get AOA. So that's a way to say I'm near the top of my class. So getting AOA is unfortunately going to be something that's going to be looked at. It's not going to be a screen, but it's going to be something that we look at on the application. So that's kind of the school part of your the first few years of medical school. In the third year of medical school, where you're doing your clinicals, those grades are they honors pass out or they pass down? Is it second year zone? There's honors pass out. That's what I thought. So, and you get a clinical grade, and a lot of your grade is based on the shelf exam, which again is a standardized test. So you have to do well clinically, and you have to do well on your shelf exam to get honors. If you don't do well on your shelf exam, no matter how well you do clinically, you're probably not going to get honors in that on that rotation. So once again, the standardized tests are pretty great. With those clinical rotations, you get comments, about your clinical performance. Do you show initiative? Are you helpful? Do you get the big picture? Are you going to make a good resident, kind of things? And those things go into your grade and they go into your dean's letter, so you can read those comments. And in orthopedic surgery, truth be told, most of us look at your grade on your general surgery, your surgery rotation, and your medicine rotation. Do we really care how you do on OB-GYN and peds and psychiatry? Probably not as critical to us. We look at it, make sure you get a fail or something. But if you got a pass, we'll probably let that one slide. But probably would like to see honors of both medicine and surgery. So, and that's where your third year comes into. And the problem is you're going to be spending your third year trying to do really well clinically on your clinical rotations, but you're going to be in the back of your mind. What are you going to be thinking about? Parts of the board, right? Because that comes at the end. You're going to have to set aside time to study. And if you have to study, it's just, what's happened is from the time that I've been program director, which is now coming up on about 15 years or so, the board scores have just gone up and up and up and up to the point where, like, I can remember when I first started counseling students, to this day I remember a student that was at 250 on the board. I was like, wow, that's a great score. Well, 250 now is like almost an average score of the applicants. So his 250 put him in the middle of the road where a long time ago it was like a score that I hadn't really seen that often. So, and the reason is probably because you have access to so many question banks that you can learn how to take a test. It doesn't mean you're going to be a good doctor. It doesn't mean you're going to be a good resident. It just means you know how to take a standardized test and you know how to do a good grade. But again, we now all these tools to try to narrow down the number of people we interview, because we are all, we're all practicing orthopedic surgeons. I see 30 to 40 patients a day in the office, and I do surgery on the other days when I'm not in the office. I don't have a lot of time to do this stuff. I want to go and read 50 applications to find out an interview, but I do it, but we all have limited amount of time. So we're all looking for ways to kind of streamline the process and make it easy. That's just the reality of the world. You have to understand. This is choosing our 3 residents isn't our full-time job. Our full-time job is running our orthopedic practices and taking care of patients. And on the side, we pick 3 residents that we want to train for the next 5 years. So I think what you want to do as medical students is you want to kind of entwine yourself into the orthopedic department as early as possible. Because you're sitting in this class and learning anatomy and physiology, and none of it makes sense as far as orthopedics is concerned. So that you have opportunities to see orthopedics as first and second year students. So number one, every Monday morning at 7:30, we have a fracture conference. A fracture conference is where our residents present the fractures that were treated in the prior week. They start off, the interns or the PGY1 start off, and they present their cases. They tend to be relatively simple and straightforward cases that they manage in the emergency room, or if they go to the operating room, we kind of move up to the ranks. So the residents present the cases, they show the x-rays, the faculty ask them questions about how they manage them, indications for the management, indications for surgery, indications for non-operative management, criteria in terms of judging their x-rays and things like that. So you don't know enough of orthopedics, but if you were to come to the fracture conference, which is in room 102 in the medical school, beginning at 7:30 every Monday morning, no one's going to ask you questions. Your medical students always, you're not going to get pinned, you're not going to be embarrassed, but you're going to start learning orthopedic lingo, right? You're going to start like when I was a medical student, I remember, when you set a fracture and you put the bones back in place, the technical term is reduction. And I remember like getting into orthopedics and people saying, well, how did you reduce a fracture? What do you mean? What does reduce mean? I didn't even know what the term meant, but that's an orthopedic term, that term that you should know. So by the time you get on your 3rd year or 4th year rotations on orthopedics, you've heard these things time and again. And people say, well, look at your risk reduction. Is that a good reduction? Does it meet the criteria of 17 degrees of radial inclination and 5 degrees of dorsal tilt? By sitting in a fracture conference, you'll just learn that by osmosis, right? They have one fracture a year in a fracture conference and go read about it and find out something about it and learn about it. And you'll be ahead of the game when you get there clinically, as opposed to walking in the third year as a medical student and not knowing anything about orthopedic surgery because you're not really going to learn it in this class for the next 2 years. So that's number one, and I think that's a great experience. You see what we ask the residents, and we're asking PGY1 residents questions. 3 months ago, we were medical students. So we didn't know that much. Now the residents actually take care of patients independently. So the things that we ask those, especially the most junior residents, are things that would be good for you to know as medical students. So that's a great opportunity. Again, Monday mornings, 7:30, room 102. Excuse me, we do broadcast it via Zoom, and you are welcome to log on via Zoom and join in and listen. I think I'm a big believer that in-person learning is better. And what's your other benefit of coming to fracture conference? There's 15 residents in the room who you can get to know after a conference. Because as they walk out the door, you might pull one aside and ask them a question about one of the fractures you saw. Introduce yourself and say, hey, Joe Schmo, I'm M1 student. I was sitting here and I have no idea. I just have a question about how they put that rod down the middle of the femur. How did you get it in there? Or something like that. Something like that. Get involved. So and our residents are, one thing I'll tell you about orthopedic residents is they're very open to teach. They do like to teach. So if you ask them questions, they're going to explain things in the way you can. The second learning opportunity, again, is in the morning, 7:30 on Thursday mornings. And on Thursday mornings, we do grand rounds. And grand rounds are presentations primarily presented by the residents, and they present an orthopedic topic. And it usually starts with a relatively basic, let's say they're going to talk about wrist fractures, because that's what they talk. They might initially start off with the anatomy and the pertinent anatomy and the surgical anatomy. Well, that's all stuff that is on ones you can understand. They'll talk about the incidence of fractures and things like that, which again you can understand. And then they'll talk about different treatment options. Again, the way they explain it, you'll probably understand a lot of it. And then this talk is the more esoteric things about maybe the controversies in the specific topic, and that will probably be over your heads. But again, you'll pick up some of it, and it'll be something you hear, so that when you get into your clinical years, this isn't all brand new to you because you're not going to get it in this class. Okay, so I think grand rounds is another really good experience. And once again, if you're there in person, no one's going to ask you questions. You're not going to get pinned, and you're going to meet people. So I think it's a good opportunity, but again, it is available via Zoom. Now, the other thing that I used to push really hard was orthopedic clinic. So on Thursday afternoons from 1 o'clock to 5 o'clock, we run 2 indigent care clinics. So they're clinics for patients with no insurance. And they're run by the residents for the most part with faculty supervisors. The one at Robert Wood is very heavy in trauma because Robert Wood is our level 1 trauma center. And the other one is at St. Peter's, which tends to be more of like office elective type orthopedic surgery. The people who are running the OIT did a great job last year setting up a schedule because we had so many students interested in coming to the clinic that the numbers got a little bit overwhelming, and there was a question how many people we can handle in the clinic. So we're doing that this year now, right?
Yeah, we just want to make sure that there's no 4th years rotating or anything. We wanted to clear with you.
So I think the number of 4th years is quickly dwindling, so I think we can start that in October.
Okay.
And again, that's a great opportunity to go. And so maybe you don't know if you want to go for orthopedics. And you go to the clinic and you're going to see us put on casts and cut off casts and see broken hands and broken legs. This isn't for me. I didn't think it's orthopedics. So you do your one clinic like that, forget it. I'm going to do something else. And so you get 1 or 2 clinics, and other of you are going to say, I'm hardcore orthopedics. This is what I want to do. And going to clinic on a regular basis and that's the way the rotations are set up, you'll get to know the residents, they'll recognize your face. So the first time you'll probably do a lot of watching, but the second time you go, they might say, well, why don't you go take a history on that patient and come out and tell me what you did? Or why don't you come in and watch me take this cast off so the next time you can take the cast off? Or why don't you come and watch me take out these stitches so the next time you can make out these stitches and stuff like that. So going to, we're trying to set it up so the students who have decided and want to go to clinic on a regular basis, go regularly, so they can derive the benefit of attending regularly. If you stand against the wall with your hands behind your back and watching, you'll be able to observe, but you'll never get any hands-on experience. And it's hands-on experience, it's fun, right? That's what you want to do. You want to touch patients and do stuff. Otherwise, you shouldn't be a surgeon. You don't want to do stuff without surgery, it's doing stuff. So you might as well get in there and get your hands dirty. And orthopedics get dirty. You play with plaster and fiberglass and blood and all kinds of stuff. So it's pretty cool. But the clinic is fun. And once again, our residents like to teach. They're gonna go over X-rays with you. They're gonna go over MRIs with you. And they're gonna tell you about, how these things are managed. And they understand your level of training. They're not gonna hit you. They know that M1s who come to the clinic don't know anything. But they want to give you interest in orthopedics. We want 10 or 12 or 15 people applying to orthopedics. We would like to be one of the most popular subspecialties at this medical school, and we are doing that. It's happening. Our numbers have gone up every year. So I think, when I was in medical school, I hate to say this, but I hated the first year's medical school. I couldn't stand sitting in class. I was bored, maybe crossover puzzles. And we had to be in lecture because we didn't have Zoom lectures and pre-recorded lectures. Now you guys, I think, you go home and watch them on a podcast and all that kind of stuff. But I was looking at a little way back there doing the New York Times crossover puzzle right there. And barely paying attention to the instructor, which is sorry to say. But it's the truth. But when I saw Dr. Joe Letty come down here and do a clinical correlation slot on the hand anatomy, that's when I knew I wanted to do orthopedics. And then when I got into third year, I saw, Rosny put down gamers and saw ACL reconstructions. I know I'm right, this is really what I want to do. So this is your chance to get in there. And if you get to know the residents a little bit, and there's time allows and your schedule allows, you can, maybe say, like, the time right now, our fourth year students are rotating and they're really trying hard. We're have a lot of students, so we don't really have a lot of time to pay attention to all of you as M1 students. But come November, they're going to be done with their rotations, and we're going to have nobody on orthopedics because nobody else wants to rotate on orthopedics, and the ones that are going in, and you don't have to, it's not mandatory. Probably most medical students should. Because even if you become a ophthalmologist, when your uncle hurts his shoulder, he's going to call you up and say, I hurt my shoulder. And you're going to go, well, I'm ophthalmologist, you. But they're going to call you anyway. So like I said, musculoskeletal complaints are really common, so you should know. But because we just don't get a lot of students. So that's your time to come and go to clinic, hang out with the residents, pick their brains, and say, I would love to see a replacement. Next, you don't have to scrub, no fancy yet, but just go into the operating room, put on a mask, and watch your hip replacement, see what it's all about. Or see a spine surgery, or see a trauma case, or whatever the case may be. We don't mind if you do that. They technically don't want you scrubbing the operating room until you've done your general surgery rotation to learn our protocol. But we have college students who come into the operating room and put on masks and hats and watch surgery. So you might as well do it. You might as well see if this is what you want to do. Again, you might go to the OR and say, that's disgusting there. I would never want to do that, or it's too physical, right? I didn't think that's what orthopedic surgery was all about. So, do it and get some exposure to it, decide if you want to do it. So I think, you have your first and second years to do that. As a third year medical student, so then there's the next is research. So again, all of you are going to get, you're probably all smart. So now you say, well, what else can I do to separate myself out of the pack? You can do research. Some of you did research when you were in undergrad. It may not even be musculoskeletal research, it's research. But in between your first and second years, that's your last summer. After that, you get no more summer vacation. So you start working like everybody else year round. But in between your first and second year, you have a couple of months. The medical school does offer a research kind of fellowship And for instance, in our laboratory, we tend to take 2 medical students to work in the lab on some of the basic science work we've been doing. The last year was very limited because they shut down the labs because of COVID, but then things picked up again. So there's that basic science if you like the lab. Otherwise, maybe you hate the lab. Maybe you think it's boring and you want to do clinical research. We have some clinical research going on. Now again, our department consists of all private practice orthopedic surgeons. We're not employed by the medical school. If we don't publish journal articles, it doesn't matter. Nobody's going to fire us because we work for our own practice. We don't work for the medical school. So I would not tell you that for a lot of us, research isn't on the forefront of our priority list. We do it because we're working with medical students and residents, and we do have academic interest. But so I tell students, this isn't the only place where you can do some research. You can go to Columbia or to NYU or to Penn or to Jefferson or to the University of Colorado or go to San Diego for the summer and have a good time there and do some research in orthopedic department there. But if you want to do orthopedics, you probably should, between your first and your second year, get involved in orthopedic research somewhere. And if there's a lot of you, there's not going to be enough research for all of you to be busy here and you have to go somewhere else. So if you have family, if you have friends, connections, whatever the case may be, come around the second half after the holidays, start planning your summer and make sure you get something on the list because research is another way to improve your application for orthopedic surgery. If you get involved with research here early, you can stick with it and kind of get involved in more projects. There's a couple of alumni. Brian Gatt is an alumni of our program, and works down by the shore. Has been very active with hand research, and he's had some students be very productive in the work he does. Dr. Paris, who does joint replacement surgery, Dr. Monica, myself, we started a sports medicine research group, so we expect to see some more projects coming online. But again, we're just not, it's not our full-time job to do research. So look for opportunities over the summer, but also you can get involved in projects, when you get to know some of the residents in clinic or in grand rounds or in fracture conference. You can talk to them about it. We do have a quarterly, not a quarterly, now 2 times a year research update, we do one in October and we do one in March, and I'll advertise it through the OIG. The residents present all the research projects. It's kind of a progress report update, and that's where you can learn about what's going on. And you can find out, we're trying to make a massive spreadsheet, say these projects need student help and stuff like that. And as soon as you see an opportunity, jump on it and get involved. Research is important. So we work our way, that's between first and second year. You finish second year, you go into the third year. Again, if you know you want to do orthopedics, it probably doesn't matter where you do your rotation in surgery. If you're not so sure if you want to do it, you might want to do surgery early and see if the surgery lifestyle is something that you like, because it's hard. You take a lot of call, you work through the middle of the night, you don't get a lot of sleep and stuff like that. Some people find out the lifestyle wise that they're not doing what they want to do. But again, when you're on that third year rotation in surgery, you get a 2-week elective block, and that's when some people will, that'll be their first exposure to clinical orthopedics. So if you're kind of sitting on the fence, you might want to do that early. The other thing is there's now elective time in the third year, so we have a lot of third year students who do a 4-week block of electives in orthopedic surgery, once again, either to reinforce that that's what they want to do or find out what they want to do. It gives you exposure to the program, so it's a good thing to do, but it's not absolutely mandatory. When you finish your third year and you decided, well, I now want to do orthopedics, up until 2 years ago, the big thing was to do away electives. But because of COVID last year, the students weren't allowed to do any away electives. And they came up with these virtual electives, which were a waste of time. And now this year, they're allowed to do one away elective, which is also ridiculous, but that's the rules. And now there's still virtual electives, which I talk to the students, they think they're a waste of time. They do them because they know, like, for instance, at NYU offers an away elective, and you think you want to go to NYU, you better sign up for their virtual elective. You learn a lot? Probably not. you get to know the personality of the program probably not. But, you know, you gotta do it, you have to get your name on the list. By the time you all become fourth-year students, hopefully all this is done and we're back to the old ways where you do 2 or 3 away electives. And so you're gonna start to plan out your career. Let's say your family's from New Jersey and you're engaged to somebody and you desperately want to, you know, be in the Northeast, and you're gonna do all your away rotations in the New York metropolitan area. If you're somebody who says, I'm sick of New Jersey and I want to go anywhere in the country, you're going to choose your away electives in other parts of the country in addition to here, so that as applicants, they realize that you're, as an applicant, you're willing to travel. Because if I get an application from a student who grew up in California, went to medical college in California, medical school at UCLA, and then tells me they want to come to Rutgers, Robert Johnson, Orthopaedic Residency, you're kidding. No, you don't want to come here. You're just shotgunning the application process. You're hoping you get an interview here. So we're not going to interview that person. Now, if that same person does an away rotation, even if they do it in, Philadelphia, at least I know they're willing to come out east, right? So that's why I counsel the students, think about that. That's question. It's not. It's not that competitive, honestly. It's competitive if you want to go to the most competitive residency program in the country, like if you want to go to a hospital for special surgery or the medical clinic. But there's a lot of orthopedic surgery programs around the country, and there's a lot of time for students. I mean, they're done in 4-week blocks. Our little program can take 6 residents, 6 students at a time, and handle that easily. So it's not that difficult. So, well, then you may need to make some connections or have somebody to write a letter. You might want to start making those connections early. Maybe that's where you want to do your summer research or something like that. That process, you want to start looking for your 4th-year rotations around the middle of, right after the holidays of your 3rd year. So that you start that process by March or April, you should pretty much have your schedule locked in for the most part. And we used to be able to tell students that they would take their part on one of the boards and they would get their scores back. And then so in the middle of the 3rd year, say, well, you got 260 on your application on your boards, you're pretty much competitive anywhere you want to go. So do your 3rd year rotations anywhere you want to go. And a student who got like a 230, you're like, well, you're not really getting into Columbia with a 230. So don't bother doing a away rotation there because you're probably not going to matter. Right? So we were able to kind of tear them a little bit because the residency here and the students are here, we're not going to have that. You're not going to know your board score until you're starting your away rotations. So it's kind of a stab in the dark, right? If you know you're a really good test taker and you know you're going to do great, then go for it. If you think you're a bad test taker, you may not want to waste your away rotations in a place where your board score is not going to be competitive. And I'm sorry, I'm blunt about it because it's the reality of the world. I can't change it. And I hear residency directors talk about it and say, oh, we've got to come up with better ways to screen these applications. Well, tell me a better way, I'll do it too. But I don't have a better way. We don't have that much time. So that's the way it is. So, again, things are changing. So the advice that I used to give a year ago is different than the advice I'm giving to you right now. This is all new to me too. So my ability is to counsel all of you when you go down this path. I'm learning a little bit as you're learning at the same time. But that's sort of the process. That's where things really kind of turn into idea. Because you do your 3rd year rotation, you confirm that you like orthopedics, you do your away rotations as a 4th year, and then we have all kinds of counseling, again, based on your performance on your boards and on your clinical rotation, about where we think it'll be competitive. The more of you that apply to orthopedics, the harder it is for all of you to get in. Because again, let's say 5 of you apply to Columbia. And so Bill Levine, who's the chairman, is gonna call in and say, well, who's the best of the five? And who's the best one? And that's a tough question to say, but we actually get it, right? If only 3 of you are applying to orthopedics, you would all say, oh, he's the best, and he's the best, because you're applying all different places, all your applications overlap. This is what happens in the real world. They're not really supposed to do that kind of stuff, but they do. So again, we also have our own internal rankings of medical students here, and we are going to try to tell people where they stand. But where you stand in our program may not be where you stand in another program. We're a small program, very cohesive, requires a lot of teamwork, and we like camaraderie. But you can go to NYU where they have, I don't even know how many residents every year, something like 15 or 17. I mean, you could graduate not even know on your own residence now, to tell you the truth. So there's a collegiality, camaraderie. It's all kind of doing your own thing there. So then that's some people flourish in that environment, and some people, drown in that environment, and some people flourish in our environment of collegiality and camaraderie, and other people don't want that, so they don't fit here. So again, it's a matter of, we try to be objective about it, but we also look at it as which students would we like to match. So we also, it's rare that we match 3 students from Rutgers. It's almost unheard of. We usually get 1 or 2 students from Rutgers here, and there are years we've actually matched no Rutgers students. But you're always, with the way rotations, that's, let's say the typical program is going to have anywhere from 5 to 30 students rotate through. Those are the people you know the best. You just spend a month that's a 4th-year medical student. That's way better than downloading an application and having them come to your interview day and get to know them for about 20 minutes and say, oh, this is the person I want here. I got your Farmer Johnson. So where you do your away rotations, assuming you do a good job and you're a normal person and you get along with people, you probably have an easier chance of being ranked highly there than you are in programs where you don't do away rotations. That's why I think selecting your away rotations is somewhat important. Now again, I counsel students, I say, what are you looking for? You want to do a lot of research. You want to be in a really high-level program. Do you hate research? Do you want to get into the operating world? Do you like having fellows teach you rather than faculty? And if people don't know, I said, we'll try different places out. Go to a small program. Go to a big program. But again, it all depends on kind of the competitiveness for these. Those are things you have to you're never going to figure that out right now. But as time goes on and you talk to residents and you talk to faculty, you'll start to have an idea of how you would like to spend 5 years of your life. Because residency is 5 years, it's a long time. And if we have a resident 99% of the time, we love our residents. The 5 years go by fast, they feel like it went by in no time. We feel like it went by in no time. But every now and then we get somebody who doesn't fit, and 5 years feels like 7 years. It's not that they're bad, we just don't check, they don't get off that well. They're still go out and they're still, well-trained orthopedic surgeons who are taking care of people. It's just that there wasn't that much fun teaching. So, I'd rather do and have fun teaching. And that's what every program wants. You want people to fit into your program. They're going to make your program a better program when they arrive. They're going to give back a little bit, not just take and stuff like that. And so all these things go into the process of your application. You all know this. I mean, you apply to college, you apply to med school. It's the same thing all over. Here's my grades, here's my personal statement, this is why I want to be there. And then get letters of recommendation, right? Your letters of recommendation are going to come from people you met in medical school, usually orthopedic faculty. Do I care if the pediatrician writes you a letter? Probably not, if you ask them for it. But I'll tell you, if the pediatrician says, hey, Joe, I want to write you a letter, I don't care what you apply to. You're like one of the best medical students I've ever had. You better take that letter. Because that letter is going to be 10 times better than you going to somebody that you met on the floor with rotation. You write me a letter of recommendation. I barely know you barely know me. But they're going to write you a good letter. But if somebody asks you, and remember that for your entire career, but you never know whose path you're going to cross, who for some reason thinks you're the best things in sliced bread. Get that letter and get it right away and put it in the file. Because that'll be an awesome letter. It'll probably be a really strong selling. So letters of recommendation are going to be another big part of it again. Because that's how once we download our 300 applications, everyone's board scores are at an acceptable level. Now what's next? It's your grades and your clinical years. It's your letter of recommendation. It's your research. It's your personal statement. And I thought this is a joke to the students who are applying it. Again, when we say like people write their personal statement, and the most commonly told story is, I was a high school athlete and I tore my ACL, and Dr. Gatt reconstructed it. And ever since then, I wanted to be able to research. I would say, if I read that again on the bottom, I've read it 1,000 times, I don't want to hear it. But that may actually be your motivation. Somebody wrote a personal statement about how they climbed Mount Kilimanjaro. And they went through this period of personal growth from the struggles of being to the top. It was such an intriguing personal statement. I didn't even care what they raised for. I just wanted to meet this person and find out more about this club. And I thought like that was pretty cool. And that's what you need to show. You need to show something about yourself as an individual that makes you like somebody that we want to teach or that orthopedic people want to teach. That we know you're going to work hard. We know that you're not going to say, well, once I'm in, I'm in. You're going to prove your worth and your value every day to your work. Because it's competitive. And to tell you the truth, we could take another person and say, you know, probably just as good, if not better. Because most of you are really good candidates. So it's not, so you got to figure out a way to separate that out. And that's some counseling with you, when that time comes for the application process. So I'm saying these are all the things you got to think of. And then, you put in your applications, most people apply to way more programs than they probably should be applying to. If you're all insecure, you're all nervous, you're not going to match. So regardless of how the match and the medical school, the deans, and me and everybody beg you not to apply too many programs so that everyone can get interviews, you're all going to do it anyway. And you're gonna rank 30 or 40 points. And then you don't match. Sometime in March you'll find out you match. And hopefully you get the place you want to go to. So it's does everybody know the match system works? You all throw your names into the pot. The match is in your favor. You're gonna get the highest program that wants you. So it's always in your favor, it's not in our favor. So you don't rank a place because you say, I'm getting way ahead of your targets. So these are the things you think about. You don't say, I'm gonna rank them because I think they want me and I'll have a better chance of getting it. It's not true. It's you just rank them as you see them and you can get the highest place that you want to go to. So I'll reiterate that a bunch of times when your application process comes. But I think right now at this stage of your career, get involved in orthopedics. Go to fracture conference, listen to fracture conference, go to grand round, listen to grand rounds, get into the clinic once our 4-year students are done. Find out if this is what you really want to do. Because it's not that easy of a lifestyle. Like I'm 58 years old and I just had to take call on Labor Day weekend and spend the entire day riding femurs instead of hanging out with my family and watching football or golf or whatever I like to do. And that's part of being an orthopedic surgeon, It involves call, and it involves working at nighttime and on weekends and things like that. So what we do may seem cool from 9 to 5, but it may not seem that cool at 2 in the morning when you're working on somebody, who was driving a motorcycle drunk and ran into a wall, and you gotta stay up all night and fix it. And you're not getting paid because they don't have any insurance, and motorcycle insurance doesn't cover what you do. So, people get frustrated with that kind of stuff when you start to see that. But I'm telling you, orthopedics is fun. It's like the best. It really is the best. So I think that would give you enough information to swallow today. I hope I've put enough of the fear of the future into you and you all take it seriously. Because I didn't know that. Nobody told me this didn't happen when I was a first year student. I kind of goofed off. And I was like, I thought everybody got into everything they wanted to do. And like midway through my 3rd year, I found out I had to work for me. I'm an idiot. I can't believe I did, but I was lucky because I did some really good research that paid off. But if it wasn't for that, I might not even be where I am today. So you guys know me this on day one. If you're on the fence, you got to work hard now. Because if you say, you know what, forget orthopedics, I'm going to physical medicine or rehab or something like that, you're going to get in really easy because you have an application that's qualified for orthopedics. And if you are, not that it's not a great specialty, it's just not as competitive as orthopedics. But you're way ahead of the game, you're like a superstar for an orthopedics and kind of like a little person. And I'm not saying that in a derogatory way. I'm saying it's, you can go in that direction easy, but you can't like goof off. And then in the 11 hours, say, I'm gonna be able to orthopedics, which is really hard, but I don't have a great record. You're screwed. You know, and some of the students, what they'll do is around, you know, they look at their record and they look at how they're doing, and they, between their third and their fourth year, what we're seeing now more and more is becoming almost standard. It's not standard, but it's becoming pretty darn close. Students are doing an extra year, they're taking a year off of medical school, and doing a full year of research at an institution somewhere. They show their commitment to orthopedics. When we used to go back 5 years, that was the bubble students. The ones who were like, yeah, you might not, you might not. They're like, take your year off, do a lot of research, show you how to do orthopedics, and that will really help you. Now, we're seeing these superstar students with great grades and just great everything, and they still take a year off to do year research. So it's becoming ridiculously packaged. It is what it is. No, I don't. I think if you're a good student, again, what's gonna make or break you? It's gonna be your varsity board scores. What research you did, you know, during your first 2 years of medical school. What do you think your letter of recommendation are, what your grades were, and all that kind of stuff. But let's say you scored 265 on part 2, and you wrote like 2 papers, and you were AOA, and you got great letters of recommendation. You don't need to do your research again. Right. But if you got 235 on your boards, and you got like you're involved in research, or you have any publications, and you got like you passed medicine and you honored surgery, and you just kind of like the middle of the road student, you probably want to do that year research in all honesty. Give yourself a shot.
I just have 2 questions. So the first one, for grand rounds, you say where that took place?
One room out too.
So same room.
Yeah, and it's also available via Zoom.
Okay. And then,
If you go to you have to kind of work your way through our website, but if you Google like Rutgers, Robert Wood Johnson Orthopaedic Surgery, you'll come to our residency program, and there's a calendar called Up To, and if you sign up for Up To, like enter your email, you'll actually get emails about all the different lectures, and you'll be able to Zoom in if you want.
and then the next question I had was also for our curriculum selection is a little bit. So this summer we only have 4 weeks instead of the normal 8 that I think previous years have gotten. So would you
4 weeks of what?
4 weeks of summer break.
Oh.
Yeah. So would you say that maybe trying to get clinical exposure versus research would be more valuable, or how would you say that we should navigate our summer program or something?
I'd probably still figure out a way to get involved in research. I use those 4 weeks to get entrenched, get involved in the project, and say, I'll do this on my free time, which you don't have much time. Right? But you have to. Excuse me here. That's water.
I actually thought of one extra question. So, how valuable would you say that previous research before med school would be? So for example, was at HSS and have some research, and I plan on continuing doing more research, but I wonder how much would that factor in?
A lot. It's good that you have that. What you should do is not stop.
Yeah.
If you have a connection to HSS, you should not let that go. You should continue that through your entire med school career. Somehow.
Thank you.
So my first one is, when you're looking at research experiences, do you only look at published papers, or do you also look at stuff like poster and abstracts?
All those count, and even something that isn't published counts. Let's say you go through going through your application, and why do you want to know how much research you've done? It's just a way to figure out how interested you are in orthopedics and things like that. But so when a student comes to me on interview day, and I read their application, I'll look at their research. So let's say they're working on something that I'm somewhat interested in, and but there's no publication that's no abstract, I'll ask them about their role in the research. They say, well, what do you do? And like, why are you doing it? If I find out that they were alphabetizing charts that a monkey could do, and they had nothing out of the experience, it means nothing. But if I talk to them about it and they can say, well, it's really at the beginning of the project where our hypothesis is X. We're trying to prove this because there's a clinical need for this particular problem, and they get it. That's what I wanted to find out. Because again, there's a lot of places where the research opportunities aren't great. But if you got something out of that experience that indicates that you're going to understand things and be a good, maybe a good researcher or just a good orthopedic surgeon or just a good doctor, that's all I want to know. But if you don't get it, you put something on your resume and you don't understand why you're doing it, you're going to hurt yourself. If somebody asks you that, they don't ask you about it.
My second question is, let's say we have an applicant who has done like a lot of great stuff, say neuro, like plastics and neuroscience, ortho. How would you like that?
So good, because it's research. And people change, people go to med school saying I want to be a plastic surgeon, and they realize what orthopedics is better. So they do want to.
Some advisors have indicated that because someone has passed fail, another thing that that's the same issue as an applicant is your community outreach or anything. Is that something that's considered or not really?
It's nice, but it's not. I'd rather know that you're going to clinic and stuff like that. I think it's a good thing, it's the world we live in. So I sometimes counsel high school students that I go to college or college or this. I tell them everybody's looking for community service, it's like months. And let's make you go to research now. Because my orthopedic residency program there and the community outreach now. You can't even be a orthopedic resident. It's a good thing to do. Everybody should do it. I believe it. I do it myself. But again, if you do it and you grow from it personally, and you can talk about it and show how this is kind of maybe your community outreach is working with underserved populations, you realize the impact that socioeconomic status has on musculoskeletal health. And you can talk to that in an interview, or talk to that in your personal statement, or form your personality going forward as a physician. Then it plays a big part, because it's something that that meant something and changed you, and you're going to carry through for the rest of your career. So it may indicate what type of resident you're going to be. I'm not putting it down. I'm saying everyone knows that you always see the resident builders, and we all are always stuck. If you don't grow from it, right? God grow from everything you did.
Like record tax distinctions, and so for students like when you go from acting, how much weight does that hold? Like these kind of like distinctions and things on your degree when applying for residency?
That's a little bit. It's just another piece of information, another thing that makes you stand out. I think the things that rank the most are if you do really good research, it stands out. If you get your letters of recommendation mean a lot. If you get a really good letter. The problem is a lot of letters of recommendation are very generic. Like, this great student worked really hard, interacted well with the hospital staff, was respectful, showed initiative. So don't send everybody's letter says. It's rare to get letters that you don't get too many letters say this person should be able to be served. They've already figured that out for themselves and they reply. You should get more. I can tell you the letters are not a bell curve. We don't have a peak of average students with a small number. Everybody's an 80 percentile. So there's 100% of people are 80 percentile. Doesn't make sense. But we're reading right now. I just for other students and how to do it. So we don't know that. But there's buzzwords that don't matter.
So you talked about competitors and high scores. Tell us a story of when someone didn't score that very high or low score that you accepted or why you accepted that first.
I've had students over the years that their scores were low, and I counseled them a lot. I said, well, look, this is what you need to do. You need to go to the look at it, show your interest in the lower tier programs. So, and the lower, it doesn't matter whether you go to HSS or whatever somebody would consider the least good orthopedic residency in the United States. If you graduate from the residency, you're an orthopedic surgeon. You may be a great orthopedic surgeon coming out of that program, but we have to be realistic about your chances. So the lower my programs back, I try to get them doing research. I try to get them to know a couple of key faculty really well, to show their work ethic, to show that they're going to work hard, get it in the letters, and send them to places and kind of call ahead and say, I know this person doesn't have the greatest application, but I'm telling you, they're a really good student. They're going to work really hard. You're going to enjoy teaching them. And it's paid off over the years. But you have to show that you're a way better candidate than your paper application shows. You have to figure you do that with your personality, with your drive and your persistence and all that kind of stuff, right? And you can definitely overcome that. It's just, it's a statistical thing, because there are some places, like I think right now, if I remember correctly, Penn State may not be using board scores as a criteria because their program director is into this whole no boards thing, but they can only interview so many people. So if you have really high board scores, you get invited for interviews almost everywhere. If your scores are low, you have less interviews means a lower chance of that. But we used to try to tell students, most students did a home rotation and 2 away electives. And I would say if you were kind of a middle of the road or lower student, I'd say take your vacation and do another away rotation. Do as many away rotations as you possibly can. And yet sometimes you have to argue with the dean's office because they're going to, this is being recorded. If you can get to an orthopedic program and show your personality in person, it's going to help you. So you might have to, fight the system a little bit, get out there and get yourself out there in person. That's my best advice for that. And find an advocate. You got to find somebody who's going to go back for you.
I'm an M2, and this is probably unique to our class when we apply for residency. But say you have an M3 that performed really well in step 1, step 2, like our current M3 class right now, and then I apply and I have a step 2 score. How are you going to compare those two applicants?
Well, why would you find the same M3?
Right, instead of a research year.
As a research year? Again, remember the board scores are just a screen. After we download your application, that's not good. Does that answer your question? Just because that person did well and did a year of research, and you did well as an M2 but decided not to do a year of research, I don't think that's going to hurt you. Because you're a good candidate. If you were a bubble candidate and you did a year of research, then you're not going to do as well as that person who did a year of research. You just got to get your application back. That's all. That's the first part. It's not that it's harder than it is, unfortunately. I hate to put all that emphasis on the board. It's not really fair, but it is. What it is.
So I have another boards question, but I'm an M3, so I have a step 1 score.
Yeah.
And say like your step 1 score is pretty competitive. Like, should I plan on taking step 2 before I send out my application, or can I send out my step with just my step 1 score?
You can definitely send it out with 57.
I guess like my question is like you don't want it to go down, right? Like, obviously.
Some days it goes down a little. And it's really true, even if it goes down a fair amount, probably doesn't matter.
Yeah.
People just kind of look at your high score. So why do we care about the boards? Why do we, as residency directors, care about your boards? Because when you finish orthopedic residency, you take the orthopedic boards, and you can't practice if you're not board certified. But it's an absolute black mark against your program from the residency review committee if your residents don't pass the boards. So who passes the boards? The good test takers. So that's one way of making sure all your residents pass the boards, just take good test takers. Again, it's not, doesn't mean you're gonna be a good doctor or a good orthopedic surgeon, doesn't mean you're gonna pass the boards. And I don't have to worry about the headache of my residents not passing the boards. I got enough of that. Don't worry about that. So that's the truth. Someone who struggles on the SATs and on the MCATs and on the med school boards, I mean, think about the pyramid, right? College, by the time you get to orthopedics, you're dealing with theoretically, some of the cream of the crop. We're not the smartest people in the world, we're pretty smart. And, you're now when you take that standardized test, you're taking against everyone who finished in the 80th percentile above. When you're in college, you're taking against like kids who are smoking pot in the back. So that's one of the reasons the boards have carried such weight. In fact, we have students or residents who struggle with the boards. Not really, we haven't had a resident not struggle on the boards in years, but then when they do it, when you look back at their old records, they just didn't do their own tests. And the way you guys study, all these questions, it's almost unfair. This is what they have. Take advantage of them, do questions. Because the questions, there's only so many questions out there. It helps, people, if you understand, if you read a question, they may ask the questions a different way next year, but they're still asking the same topic. So for a while, you do it, from 5 different angles, no matter what you see, you're going to get. I see part of that, because I don't believe in studying for the test. I believe in studying to be a good doctor. You guys are taking care of me when I'm old. I'm already old, but when I get older, you can take care of me. And I'd rather be a good doctor than be tested. And that's what I tell my residents, when they come in, we tell them, we want you to pass your boards. But what's more important is you're an honest, ethical, good orthopedic surgeon who I would send my family members. That's what I care about in my graduates. I don't care that you want to solve they pass. They're supposed to do the same way. And they do. You don't get a gold star for doing well on the boards. You don't even know what your board passes. When you pass the orthopedic boards, you get a grade, but nobody knows what it is. You just pass. It's like pass down. So if you get 100 on the board, you get 35, which is passing score, you pass. You're the same as the person who got 100. So your patient's somewhere, your partner's somewhere. The hospital doesn't know. Only you know. And the American Board of Orthopedic Surgery. Any program director, because I need to see the score. I don't really care. It has. We're all going to standardize, everything standardized. Medicine's an art. It's an art of medicine. If you don't believe that, you never be as good as you do. It's not, you don't follow the flow sheet. Every patient's different. Everything you deal with has it from you down to practice medicine. It's the best. It is fun. I'm telling you, the residents are fun. Get in orthopedics and they realize how fun it is. And it's just going to make it all want to do more. Okay? All right, thanks, everybody.